Silicone balloon catheters are often used in hospitals in daily routine when inserting a catheter for renal calyx drainage. However, balloon catheters have not completely replaced the use of nephrostomy pigtail catheters. So the key question is, why do these two product types legitimately need to exist side by side?
Genau mit dieser Frage.
This is exactly the question we want to address now in the form of an expert discussion. I am very pleased to be joined by two highly experienced colleagues. On this side, we have Dr. Britta Kühl. She is senior physician at the Municipal Hospital in Lüneburg. She worked as a specialist with Professor Fisch in Hamburg and then later at the Asklepios Clinic alongside Professor Gross. Since 2020, she has been working in Lüneburg with Dr. Olianas. On the other side, we have Dr. Björn Kaftan, senior consultant at the Lüneburg Municipal Hospital, who, interestingly enough, also began his training in Hamburg-Harburg with Professor Schreiter and Professor Fisch. In 2006, he significantly expanded the clinic in Lüneburg alongside Dr. Olianas. So, yes, the topic of percutaneous nephrostomy certainly has a high significance in daily urological practice. Percutaneous nephrostomies are a regular part of our day-to-day routine as urologists. That's because we have to carry out urinary diversions based on different indications. This can be, on one side, an acute situation, such as urosepsis, for example, in the case of a ureteral stone or a drainage stenosis. But it can also be a long-term drainage with a palliative indication in patients with advanced tumors. We want to see which type of urinary diversion, which type of catheter, whether pigtail or balloon nephrostomy, are of advantage for which indications, and then discuss this in detail intensively. May I begin with you? What position do you use when performing a percutaneous nephrostomy?
Well, I learned to perform this procedure in the prone position, like we all did. Now I place patients on their back in a supine position, so I can turn them slightly to their side. In Lüneburg, we do it in such a way. This has proved to work for us, that we cushion the pelvis and the thorax so the flank is exposed, which then provides us good access from this sideways diagonal position.
Are there particular indications for working in a prone position?
Very rarely. It's become the absolute exception. Primary nephrostomies, like percutaneous nephrolitholepaxies, are in general performed on patients lying in this modified supine position.
Another question, perhaps. In acute cases, is the procedure performed under local or full anesthesia?
We use both, depending on the case. For some patients, local anesthetic is not suitable. But usually this is clear beforehand.
Good. So the patient is in position, in the so-called supine position, which is becoming more and more popular. Which puncture technique do you use? Do you use ultrasound with a guide? How do you tend to work?
We always use an ultrasound-guided puncture system with a puncture aid. And we use the standard needle for the puncture. During difficult nephrostomies, we first fill the renal pelvis or the cavity using a neuroforamen puncture needle, and then, as a second step, puncture the cavity with the hollow needle. If in certain cases it's not possible to puncture the cavity with the hollow needle directly, then first we fill it, and then in parallel we enter the cavity with the puncture needle using X-ray monitoring without ultrasound guidance.
I imagine X-ray monitoring plays an important role here. What are your requirements for a good puncture needle?
Well, if you're using ultrasound guidance, then the needle has to be well visible in the ultrasound image. Our needle has a trocar cut at the front, which makes the tip visible and provides you with exact guidance, allowing you to easily follow where you are.
The next step is laying the guide wire once we are inside the cavity. So, regardless of which technique you use, which kind of guide wire do you like to use? Do you have any preferences?
My preference is for hydrophilic wire because it's easier to place. You have more options and the risk of injury is not as high.
There is also a rigid wire, the so-called Lundequist guide wire, which is also found in some sets. Do you also see an indication for this?
Personally, I use a standard wire for every primary puncture and only use hydrophilic wires for difficult punctures. For example, when the wire has to be inserted into the ureter. As a very stiff wire, the Lundequist is especially suitable for dilation in cases of scarred tissue. Because the softer the wire is, the greater the risk of dislocation. However, there are also hydrophilic wires that are not soft and slippery along their entire length, but are also extremely stiff in the middle section. There are also other hydrophilic wires made of combined materials, which become very stiff towards the back end. So at the moment, I think that standard wires remain an excellent option for us in the case of simple punctures, or when we have scarred punctures that are difficult in terms of bouginage. The advantage of hydrophilic wires, of course, is that they can be placed. For example, in case of a narrow lumen, if stones have to be passed, or if the cavity is very small and narrow. This allows me to carry out a safer puncture and placement of the wire.
Now, the next step, I think, is to dilate. Some people think you don't have to dilate. What about you?
Since I always like to insert the 10 Charrière balloon fistula, I have to dilate a bit, of course. There are 2 dilators in the set, and you don't necessarily have to use both of them. You can also take the larger one and then, if you're fast, use the Nephro-Quick system immediately afterwards.
Could you tell us a bit more about the Nephro-Quick system? What is the trick there?
With the old system, you have this hollow sheath that you then peel away afterwards. Of course, you first have to bougie to 11 Charrière, one size larger, and then the problem is that you've completely drained the renal pelvis before you've placed the fistula inside. That is the first shortcoming, and if it slides out, that's not good. The second problem is that when you insert the catheter and peel away the sheath, it can sometimes cause everything to slide out again. And with the Nephro-Quick system, the catheter has an obturator. You just have to bougie to 10 Charrière and insert the stiffened catheter with the obturator inside. Then you pull out the obturator and you're done.
That is actually similar to the pigtail. Here you have an obturator inside and a balloon catheter outside, as opposed to an obturator inside and a pigtail outside. So it's the same as when you use a pigtail, right?
That's right. There's not a big difference in the placement. However, the balloon catheter may cause a problem to occur in the kidney, because the placement of the balloon makes it difficult to place the fistula. This means that if I have a small, narrow cavity, as I just said, the balloon can cause it to burst. Sometimes I can't place the balloon without the small tip touching the wall somewhere at the back, which means that the drainage performance is not ensured. And the risk of injury from potentially large residual concretions, if you have not carried out a complete stone treatment first, is also present with the balloon fistula. This is why, although we use the balloon fistula as standard during percutaneous nephrolitholepaxy, we also fix it in place. Because it's not uncommon to have to deflate the balloon on the catheter in order to have the corresponding drainage effect.
Ultimately, however, you can decide how much to block the catheter, and you can add a contrast medium during placement to see if it runs out when the catheter is positioned in the way it is. If I have a very narrow cavity, I don't have to put in 2 or 3 milliliters, just 1 will be enough, so I can remain flexible.
Yes, so what do you use as a filling medium? A salt solution?
No, I always use a 10% glycerin solution.
Since the glycerine solution has been in use, we no longer have these fluid losses, so the catheter also remains safely secured in place.
That puts it into perspective. How do you fix the pigtail?
The pigtail is fixed in place with a suture, and then once more with the plaster strip, which is then knotted over the bar.
And is that safe?
It's a safe drainage with a safe fixation. The risk of dislocation for the pigtail drainage is greater than for the balloon drainage, but of course it has easier, more atraumatic and better placement possibilities during primary care.
The problem, however, is that it tends to slip out again quickly, even after a few days, and you then have to insert a new one with the associated trauma for the patient.
That's correct. However, if I use the balloon drainage, it's not possible to place it in such a way, maybe going past the renal pelvis into the upper calyceal group or even straight into the ureter, that will enable me to prepare the guide wire for further transformations in the next steps.
You must have this clinical experience. Let's say you place a balloon nephrostomy, obstruct a prostate carcinoma, and then take a guide wire, a hydrophilic one again, and insert it. Would that be a problem?
No, it's fine. They are not only available with a straight tip, but also with a curved tip, and this gives you the option of changing the direction a bit.
So you can still get in. That's good. Do you also put a suture additionally?
Only in rare cases. If, as just described, the stones are still there and have not yet been treated, and if I'm afraid that they will scratch the balloon and destroy it somehow, then I would make a suture. Or, if the patient is not compliant, and I expect that they will keep pulling on the tube, then I would make a suture as well.
So does something usually happen to the balloon? Does it get deflated?
It rarely comes out intact, but the advantage is that you can get it back in more quickly. This dislocation usually occurs relatively late, and the canal is then consolidated to such an extent that you can insert the wire and quickly insert a new fistula.
The pigtail catheter reduced trauma. Do you think, or is it your experience, that if you now bougie once or twice, that this is a greater trauma for the kidney?
I don't really think so. I think the difference between putting in an 8-Charrier pigtail and a 10-Charrier pigtail is marginal.
Finally, we might want to talk briefly about the costs. Has the use of balloon nephrostomies had a big impact on cost reporting in the clinic?
No, at the moment, balloon nephrostomies do not play a major role in reporting because we only use them in long-term care and not in primary care. And the sets are now so easy to use that we don't have to train the staff as much. Meaning we can save on training costs and through eliminating incorrect use, because the purpose of the set is clearly defined.
And as a senior physician during night duty, are you called in to perform the procedure, or does the resident also carry out the percutaneous nephrostomy?
The more advanced ones do, yes. Above all, because we have endoscopy nurses who, and that's unique to our clinic, not only work in urology but also in other departments. So you may have a nurse who hasn't handled the procedure so often. She can manage it. But if you tell her to locate the individual parts, then it becomes more difficult.
Yes, I think these sets have a lot of advantages. The downside, of course, is that if you have something in there that you don't use, then it's just in there. Yes, I think we have actually summarized everything very nicely. The advantages of the balloon catheter have been presented very clearly. On the one hand, there are clearly cases for the pigtail catheter, namely the delicate cavity and the special application. I think that's clear. On the other hand, we have all the benefits of palliative long-term care with the use of balloon catheters. That is undisputed. And we'll see in future how this field develops when it comes to acute drainage, urosepsis, and other situations where we might also want good, stable, immediate drainage. But I'm thinking about the benefits and indications for both products to exist in parallel, about which there is no doubt. Thank you for your interest. My name is Professor Jens Rassweiler. Thank you both for this interesting discussion among experts.